Next, we have Dr. Naik, who is the Chief of Cardiology and Director of Structural Heart Interventions at Dignity Health St. Joseph's Hospital and Medical Center in Phoenix, Arizona, where he holds a clinical professor position at Creighton University School of Medicine. He completed his medical and cardiology training at Albert Einstein College of Medicine, as well as an advanced interventional and structural fellowship at Cedars-Sinai Medical Center in 2010. His expertise encompasses structural heart disease and complex percutaneous coronary interventions using cutting-edge mechanical support technologies. Dr. Naik is a clinical investigator in international multi-center clinical trials, co-authoring numerous peer-reviewed scientific articles. Additionally, he serves as a national and international clinical proctor for transcatheter valve implantation and repair, offering advanced training courses in both coronary and structural heart therapy. Dr. Naik will discuss diagnostic management and continuous monitoring post-complex PCI. Dr. Naik, the stage is yours.
Thank you, Dr. Kaplan. That was a kind introduction. I appreciate that. So we're a big high-risk complex PCI center, and so what that means is where ejection fraction is very important to us. That's what we're trying to improve. That correlates very well with patient outcomes, obviously. So we think that there's a big population that's not very well treated, mainly surgical turndown patients. And with the advent of new technology and better systems to use, we're able to treat these patients. So what I'm going to do is show a typical case that we offer Guardian to, a typical patient. It's a complex PCI patient. This is a 63-year-old. He had diabetes, hypertension, and COPD. He presents with shortness of breath and angina on exertion. 2 years ago, he had an LAD drug-eluting stent. His circumflex at that time was described as 100% occluded, and his RCA had some moderate disease. 6 days later, had stent thrombosis that led to a second stent proximally. Currently, his cranial is 1.9. His ejection fraction was 25%. So at 25%, he's not a Guardian candidate for us yet, but he does deserve complex PCI. As you can see here, he has a chronic total occlusion of his circumflex artery. His left main LAD has issues and an EF of 25%. So he was a surgical turndown. This is what's important. These patients are now being treated. So this is what I want to kind of illustrate is that before, these patients were going to either medical therapy because of surgical turndowns and not living that long, or really just going to hospice automatically. And so we're treating them now. So his plan was the plan after discussion with our whole complex PCI team, which includes surgery, a heart failure cardiologist, a cardiologist, and myself, an interventional cardiologist. We decided to proceed with high-risk PCI and with Impella CP support, percutaneous mechanical circulatory support. And our goal was to treat the CTO of the circ, his LAD, and left main. So go ahead, next. And that's what we did. We opened up his circumflex artery, and we used the shock wave based on IVUS, which is another tool that helps us achieve complete revascularization, which improves EF. And so we fixed the circumflex artery. You can go to the next slide. But we also fixed left main and LAD with another stent, and he did well. Actually, post-op, his 90-day follow-up, his ejection was 40 to 45%. So what that means now is we've done all this work to get his EF to 40 to 45%. All this PCI, and like Dr. Kaplan said, ACS patients, as he's shown in the LERS trial, have a higher risk of having further events, obviously. And so we don't want to go backwards, especially the hospitals don't want you to go backwards because a lower EF means more heart failure hospitalizations. But us as cardiologists don't want our patients to go backwards because of a low EF. So this is the key. The preservation of ejection fraction or improving ejection fraction is king. That's the king to hospitals. That's the king to us. I think all of us on the call are cardiologists, but everything, I have a different discipline. EP has a different discipline. Heart failure cardiologists have different discipline, but it all centers about heart failure. So heart failure can go to complex PCI, can get a bi-VA ICD, and now I think an ejection fraction more than 35% ACS patients, they can get a Guardian too, because what are we trying to do? We're trying to make sure that the ejection fraction doesn't worsen and we preserve the ejection fraction. So I think it's very important in patients like these, especially since they could be having silent MIs and worsening MIs that lead to a decrease in EF without us even realizing it. And again, spending all that time, equipment, cost to get them out of hospital, improving EF, I think these patients deserve a guardian, so to speak. So that also it helps with it impacts our time to door for heart attacks. Time is muscle, like what was already mentioned. If you have if your chest pain to procedure is less than 2 hours, you're not going to lower your EF. If it's more than 12 hours, then yes, they're going to have some EF issues, ejection fraction issues. Early arrhythmia detection is important, but again, in the end, you can read it yourself. But it's like having. We used to say, when we use the Impella percutaneous mechanical circulatory support in high risk PCI, it's like having a seatbelt. You don't need it every time, but when you need it, you really need it. And so it's the same thing with the Guardian. I think you're not going to need it all the time, but when you need it, you're really going to need it, because then you're saving the patient's EF. So that's kind of where this is just an example of this is a typical patient of ours with complex PCI, and we're starting to feel more and more comfortable offering Guardian to patients like this overall for our heart failure program. So thank you.
Thank you, Dr. Naik. I think you hit on some very important points, especially showing how once you've put in the work to salvage muscle, you want to make sure that you don't have another event and lose all of that progress.